on organizational approach to assessment. And we'll be having this session on a virtual platform. And we have Dr. Farhan Bhanji, Professor of Pediatric Critical Care and Vice Dean Education, Faculty of Medicine and Health Sciences, McGill University, Canada. Good morning, sir.
Good morning.
And we have chairpersons for this session, Dr. R. Lata, Professor of Microbiology and Vice Principal Academics, Arupadai Video Medical College, and Dr. Raghu Nanthanan, Professor of General Medicine, Madras Medical College, Chennai. I request the chairpersons to adorn the dais.
Good morning, everyone. Good morning, Dr. Farhan. What's the time there?
It's 12:50 a.m.
Oh, okay. It's early, very, very early morning. Good morning. I would like to introduce Dr. Farhan Bhanji. He's a professor of Pediatrics, Critical Care and Vice Dean Education, Faculty of Medicine and Health Science, McGill University, Canada. He has done his MD, MSc, FRCPC and FAHA. At present, he is a Director of Education at the Steenberg Center for Simulation and Interactive Learning and an Associate Member of the Institute of Health Science Education. He is also a leader in resuscitation education for the Heart and Stroke Foundation of Canada, chairs the Educational Science and Programs Subcommittee of the American Heart Association Emergency Cardiovascular Care, and co-chairs the Education, Implementation and Team Task Force of the International Liaison Committee on Resuscitation. He has graduated from Master of Science program at Maastricht University in 2008 and has been fortunate to receive the Kaplan Award for Clinical Teaching from the Pediatrics residents at the McGill 2007 and New Educators Awards from the Canadian Association for Medical Education, CAME, in 2009. He was the inaugural recipient of the Richard and Sylvia Chris Scholar in Medical Education and serves as the Director of the Fellowship in Health Professions Education at McGill. In 2013, Dr. Farhan was a visiting professor at the Medical Education Development Center in Gifu University in Japan. Current research of interest for Dr. Farhan is assessment, CANMEDS, simulation-based education, optimizing resuscitation-related education and technology, and enhanced instruction to improve clinical training. This is the brief introduction of Dr. Farhan Bhanji, and today's talk is Organizational Approach to Assessment. Welcome, Dr. Farhan Bhanji.
Thank you very much for the welcome, and thank you very much for inviting me to present. It's such a great opportunity to meet many of you, and I'm sorry I'm not there in person. There were some political issues with Canada and India, unfortunately, a couple of months ago, which stopped us from being able to get visas. But I hope that we can get a chance to meet in the future and to go over some of these discussions in person. So, really, we're going to talk about some organizational approaches, and I hope that other presenters of this conference will build on what I'm speaking about. I speak or I work often in English, so I do tend to speak quickly, and it's late at night, so I speak a little more softly. So if someone can let me know if I'm too quiet or too quick, please let me know. So this is me at the McGill School for the Gifted, and pushing instead of pulling. And I put this up there because I really firmly believe that when you prepare for a presentation and have the opportunity to work with such bright colleagues, that you actually learn more from the people that are there. So you can't do a presentation on assessment and not show Miller's pyramid. This is probably the most widely quoted piece of literature in medical education, and it's interesting that if you read the original paper, it's really only a short summary of a conference presentation that we did. But really the concept is to think about assessment and to move further up the pyramid. So for those who haven't come across this previously, at the bottom of this pyramid is what somebody knows. So that's what they can recall. That's when you do a what we have in education, in undergraduate education, well, we need to do more than that when we're thinking about the assessment of confidence as we're thinking about systems here. If you want to know how somebody interprets and applies information, that's knows how. And that could be essays, short case presentations, that sort of discussion. Moving up the grid is seeing what somebody shows that they can do, or shows how. Those are simulations or auspices. And what you really, really want to get to is what does this person do in clinical practice? So that's watching them in the workplace. And how we think about workplace-based assessment as we build a program of assessments. So I would say this is one of the key slides, is really thinking about an assessment program. All of these individuals are touching an elephant, and they're getting different perspectives. So touching the ear, you think that it's a fan. Touching the tusk, you might think it's a spear. Touching the trunk, you might think it's a snake. If it's the legs, it's a tree. Only by putting those pieces together do you get an accurate reflection of it being an element. And that's what clinical assessment is about. And that's why we should think about it for our learners, is how do we get multiple pieces of information. And MCQ is not bad. It helps you to understand what somebody knows in terms of the knowledge base. But how do you build a program of assessment as you're thinking about assessing an individual, and build in all the pieces to make those right decisions about learners. So talk a little tiny bit about validity. I really like this slide just to quickly describe things. So if you keep shooting at the same spot here on the target, but it's not the center of the target, well, that's reliable, but it's not valid. If you keep hitting the center of the target consistently, that's reliable and valid. If it's all over the place for the arrows, well, that's unreliable and that's not valid. You need the reliability, but its reliability is necessary, but it's not sufficient for validity. In order to assess somebody, you need to think about your organizing framework. This is what we use in Canada, in about, I think, 30 or 40 jurisdictions in the world that have taken this on. It's very similar to the ACG competencies. It's similar to some of the competency frameworks out of the United Kingdom. It's just the one that we use in Canada right now, and we're going through a process of revamping it. But at the heart of our framework is medical expert. But you can't deliver good care as just a medical expert, and you don't want to just assess their medical knowledge. In order to do patient care, you need to be a good communicator. You need to collaborate with other team members. You need to lead the healthcare system. You need to advocate for your patients. You need to be a scholar, be able to lead literature to teach. You need to be professional. And that's our concept of what a organizing competency framework is. And I think it's important for all of you as you think about how you want to assess. You need some framework to look at and say, what am I assessing against? And how do I get everybody to understand what those key elements are? So validity. I would tell you that validity, we've always thought about it, is this a valid tool? Or is this a valid assessment? And I would argue with you that validity is not a property of a tool. And it's not a property of a test. It's you build an argument for how you use it. And if you can build the argument and justify how you use it, that is what the validity is all about. We'll talk a little bit more about that. So this is a tool. It's a hammer. And if I have a nail and I have to put a nail into a wall, then it is potentially a valid tool to do that. But a couple of things to really think about here. If I were to give this hammer to my daughter, who's 9 years old, and ask her to put a nail into the wall, versus if I was using it, I think that I would have greater success in putting the nail into the wall than my daughter would. But I think the validity doesn't rest with the hammer. The validity is with the person that's doing it. And that's a key piece of all of workplace-based assessment as you think about the system, is that you're reliant on the people that are doing the assessment to score appropriately. Now each hammer can look a little different. The handle could be a little bit shorter, the hammer head could be shorter or bigger, and there might be some shapes that are better than others. But ultimately, to put the nail into the wall, which is what you're assessing for, it really comes down to can the person use it. And so if you have any tool in person knows how to use it, it will get you the validity that you're looking towards. So there's a bit of a disconnect in how you think about assessment. There are past ways of thinking about it, how I encourage you to think about it going forward. The way that I tend to teach about this and have people think about it is like making a diagnosis in a clinical setting. We all understand what this means. Sometimes you can make that diagnosis with a history and a very short physical examination of an individual. So it doesn't take me very long to diagnose that this is an asthma exacerbation. Probably a few questions, quick listen to the chest. I know this is asthma. I'm not doing any other tests. I'm fairly confident in my decision. What do we do when it's getting more complicated? I'm a pediatric intensive care physician. If it's getting more complicated, I take a longer history, more extensive physical exam. I might get ancillary tests to help me more information. And gather more information until I finally make that diagnosis. And that's what we need to think about our learners. I've got enough information. When we have our most challenging clinical situations, for those of you that are clinicians, think about what you do. The way you handle a complex clinical situation is you gather people together. You gather your colleagues, other specialists or subspecialists, and you think about the case together. And with that, you actually come up with a diagnosis more often than you manage your platform. That's what we need to do in assessment. I'm not sure what the numbers are in India, but it's very true in Canada, in Australia, and in the UK, that we have colleagues that are not confident because they don't understand medicine, and we have colleagues that are unprofessional and problematic because of that. Rarely do assessment forms actually capture unprofessional behavior. We never capture that as we write it. But we do capture it when we talk about individuals. And if we really want to look at this in the Australia, what they found is that 1% of physicians, 1% account for 25% of the patient complaints. 3% of physicians account for 49% of the patient complaints. We need to be able to identify those individuals. The reality of it is that they're often there in medical school, they're often there in residency, and we've identified some issues, but we don't leave them out, and they go on into practice and find patients. I think we need to think about how we're identifying those people, and a group conversation actually brings us that a little bit better. So what are the things in validity that you need to think about? There's 4 things in Kane's validity model, very similar to Messick's. We prefer Kane's just because it's simpler to explain and understand. And the way we think about it is there's 4 things that you need to look at. 1 is the scoring, 2 is the generalization, 3 is extrapolation, and 4 is the decision of the implications of that. And I'll walk you through each of these so that tell you that. The argument-based approach is that you state what the purposes of your assessment and you gather some evidence to say, does this make sense or does it not? And walk through each of the components that help do that. If you have a lack of evidence, and I think that this chains, links in a chain, and if you have a weak link and that link gets broken, you don't have validity evidence. And the bigger the decision that you have to make, the stronger your chain links have to be. So if I'm making a decision about a simple test in first year undergraduate medicine, that's not a final exam that counts for 10%, I don't need strong validity evidence. I work in national certifying exams at our Royal College of Physicians and Surgeons. We make decisions about whether physicians can practice or not. We need to have much better validity evidence to say whether a test is valid or not. So scoring is you provide a stimulus, whether that's a real patient, whether that's an auspices patient, whether that's a multiple choice question, whether that's a short answer question and an essay. It brings out a response from the learner. We then see an observed performance. We create a score. Most often, we use numbers. But I'll tell you, I was a calculus major before medicine and a statistics teacher. And we don't understand what it means here. We translate their performance into a number, but it's not a scientific number. Because somebody got 8 out of 10 doesn't mean that they're doubly smart for somebody who got 4 out of 10. So the numbers don't have the same meaning as they do in other natural experiments. But we still use that and we transform it into score. But what we want to do is to make sure that everybody gets the same test, they're all getting the same material, and the same scoring. You can imagine all of you viewing the same scenario, same communication scenario, and you might score things differently. And that's one of the key things about it. As you're moving from a multiple choice question that have a clear right answer or wrong answer, up Miller's pyramid to what somebody's doing in a clinical environment. And in the clinical environment, there's much more variation with how we think. So training those raters and supporting those raters is going to be a key piece in the assessment. Generalization is, there's a million things that it takes to be a doctor. We can't watch somebody every single day for every single encounter. What we need to do is get a sample of that and say, okay, we've seen enough of a sample, we know that you're good enough. And that's a key thing with assessment. As people start to build systematic assessment programs, they have a tendency to go from we have no assessment to then asking for hundreds of assessment points for each thing. The reality is you just need enough, 10, 12, 15 measurements, and that will give you a good sample of how the person's performed. Extrapolation is something that's important for if you've got an OSCE or a written test. You want to say, does that, can I take an inferential leap and say that's how the person will perform in the real world? And that's to kind of tell you that, right? So performance in a simulation-based environment, what you want to do is predict how they're going to perform in a novel clinical context. And that inferential leap is the extrapolation that we want to go through and say, how can I get this closer if I'm doing it in the testing model? And the implications are, what are the positive and negative effects of assessment on the learner training program patient society? If your assessment keeps qualified people out of practice because they failed the exam, then that's a problem in terms of the validity of the assessment. If it lets people that are not competent into practice, that's a problem with the validity of the assessment. So that's the fourth piece of K-12 people. That's complex, it's hard. I think it's worthwhile to sort of understand some of the framing. What I mentioned before is the wisdom of crowds. When you want to do something well in medicine, get together and get our brains together. This is a key principle of assessment. How you design an assessment program is best done if you do it right. How you make a decision about an individual learner, are they good enough or are they not good enough, is best done by a group. Taking that away from a single individual in that group setting identifies professional conduct issues, but it also allows a more fair and open process that the judgments that come out of it. So there is something in terms of the wisdom of crowds and decision making. I'm going to change gears and have you think of a system here, and this might help you think about things. When this comes from the Ottawa Conference on Assessment and what the critical pieces are for a framework for good assessment. If you start with what the purpose of your assessment is it a low-stakes test or formative assessment that you want the person to learn from? You'll factor in different things than if this is a high-stakes exam, this decision of whether somebody can practice in medicine or not, a certifying exam. But there are common principles you have to think about in each circumstance. One is the cost effectiveness. That's the financial cost of building an assessment, that's the human resource cost, that's the opportunity cost of the things that you can do. We, in clinical medicine, if we have somebody that comes in with a cough, fever, we listen to their lungs. If we're not sure, we make it a chest x-ray to see if they have pneumonia. We don't order a CT scan. We go for the test that's most relevant for the circumstances that will cost it. The same rules should apply in assessment. And this is why it was like a diagnostic test. The next is acceptability. An assessment has to be acceptable to the learners. It has to be acceptable to the university, the teachers, the certifying college, and society at large. In medicine, we can't suddenly say we're getting rid of all this. Reliability we talked about, validity we talked about. And the last thing I have you think about is the educational impact of the assessments that we're using. Using multiple low-stakes assessments to get a flavor of the individual learner can actually help them to improve and have a positive impact. Having multiple higher-stakes assessments can actually be negative to learners and affect their wellness and help them and put them into a negative state. And that's something we have to think about as we build our assessment programs. The last piece is the catalytic effect. When you have large pieces of assessment data, you can actually form programs. So for instance, we use our Royal College examination data, and if all the residents in cardiology are doing poorly in their electrocardiogram interpretations, we will feed that back to the training programs so they can improve their training programs for candidates to get that information. One cautionary tale about workplace-based assessment, and we have gone to, in Canada, we've gone to competency-based medical education. We've gone from very little assessment of clinical competence to many assessments. The thought that it was that it would improve our assessment abilities, but what we've learned is that it's not working in every circumstance. And this comes from Amy Edmondson, who's at Harvard University and a business professor. But she really talks about low and high psychological safety. When you have a system where learners don't feel safe and it's low psychological safety, and you institute high standards like you would with multiple assessments, you will create anxiety and stress in the learners. If you have a situation that is high psychological safety, where learners trust the faculty, and it's clear that that's the case, and the environment's safe, and feeling mistakes is safe, then having high standards there with high performance in people learning and optimal improvement. I think much of where we are in assessment right now, is really down here. We have low psychological safety and low standards, and we're really in an apathy zone. And learners don't care about it, and I think we want to improve them. But I would caution and say that the key thing is, if you want to move towards this high performance, what you need to do is create high psychological safety first, and move in this direction upwards from apathy to comfort over to high standards. Well, what's the key issue? What's the key challenge? Faculty development, faculty support, faculty time to build these assessments. And if I can speak to your senior leadership, that's the key. Assessment doesn't fail because we poorly designed tools, we haven't done the work there. It's because the faculty don't have the time, and the faculty don't have the support that they collect at their assessment. If you're designing new assessment forms and you're not taking things out of the literature, create a form and then teach them how to use it, talk to them, see how they think, and create forms for them, and don't make them too long. If your purpose is to make somebody improve, remember, you want written comments, because written comments are how somebody improves, and focus away from numbers. And those written comments can actually be quite reliable, quite well. Moving forward and thinking a little bit towards the future, right now, one of the technical skills, which is a small circle, or whether you're assessing the individual person as a leader, that's a larger circle. Healthcare outcomes don't relate just to that. They relate to the entire team here and the system. And I think we need to have more assessments that are starting to look away from the individual, but more about the team and how are they performing. And finally, I think we need to think about the future. Right now, we assess communication skills. The future, how do we get the patient voice there? We are not the experts as to whether that communication was okay or not. It's the patient. So how do we include that? There's a talk coming up on artificial intelligence. Artificial intelligence changes how healthcare is provided. So what do we assess? Maybe different in the era where there's AI. But how do we assess them? Can AI assess? And literature coming up from our institution, McGill, is yes, it can. And artificial intelligence can be used to assess students. How might we use simulation or online technology to take away some of the burden of assessment? How can we use virtual reality? Is there opportunities to use crowdsourcing and getting the public to do that? And those are some of the things that are coming down the pipeline as systems evolve. So with that, I'm going to stop. Open up for questions or comments. Maybe me ask some of you to think about where do you think assessment is going or should be going in the future. And I want to hear your thoughts around this, because I think the more dialogue we have, the better we all move towards the future. So I'll start by sharing and see if you have comments, questions, thoughts.
Thank you very much, sir, for your very scholarly and thought-provoking talk on the nuances of assessment. You have rightly brought out the 4 components of scoring: generalization, extrapolation, and implications. And you have rightly said how to convert the performance into scoring so that there is uniformity, and every student should be given the same test, and so that the scoring is also uniform, and we expect everybody to get the same scoring. And you have attributes of the assessment. You have nicely brought out in a mnemonic carve, talking about cost, acceptability, reliability, validity, and educational impact. And I think the audience will also agree, in our situation, the feasibility is also to be considered. Whenever you are adding a attribute of an assessment tool, the feasibility is the main challenge in our day-to-day implementation. So it's a very, very thought-provoking and very scholarly talk. Maybe a few questions, 1 or 2 from the audience. If anybody wants to ask, sir, we can take up.
The QR code is projected here. You can put up your questions scanning the QR code also. So those queries will also be addressed.
And also you concluded with the use of AI and machine learning and other gadgets that we are now facing, how that can be also put into our assessment tools in days to come.
It's very interesting you bring up the point of feasibility. Our chief psychometrician and I always discuss this, and we fight about it a little bit. He separates it from cost effectiveness. I include it. And I say if it's not feasible, it's not cost effective. He puts it as a separate entity, and we have debates about that all the time. I think it's interesting how you think about that. I think it's very valid. How you think.
Sorry for the crosstalk. Any questions from the audience? Okay.
So I think we can conclude this session with a big round of applause for the excellent talk.
Thank you, Dr. Farhan Bhanji, for an excellent talk. We'll be sending you the memento to your, right now we are not able to give as a token of love. We'll be receiving it at your place. Thank you, sir. Now I would like to request, call upon Dr. Alka Segal, Professor OG, PG Mach Chandigarh, to present the mementos to our chairpersons, Dr. R. Latha and Dr. Raghunandanan from Chennai.